So welcome to the gastrointestinal, genitourinary, gynecology, and obstetrical emergencies. Not only is that a really, really long title, but it also encompasses a whole lot of questions. If you look at the blueprint for the CEN, there's 18 questions out of this area, making it one of the larger areas on the exam in regards to number of questions. That's about 12% of the total questions will come out of this area. So you can imagine that we're going to be spending quite a bit of time together to get through all of this material. But as we do in all the modules, we're going to start with a challenge question. So which of the following goals of treatment is appropriate for a patient with pancreatitis? A, increase in the pulse rate. B, elevation of serum glucose. C, decrease in serum calcium levels. Or D, reduction in core body temperature. What's your goal of treatment, or the most appropriate goal of treatment anyway? Now I'm going to keep moving. Of course, you can pause if you need to think about that a bit, and I will give you the answer a little bit later. So we're going to start with a topic that was added to the CEN blueprint in 2022, and that is cyclical vomiting syndrome. To be honest, this is kind of, to me, an odd topic to be added, because I don't want to suggest that we may never see it in the ED, but it's just such an obscure topic that I was a little surprised they added it. But we'll go through the theory because you may get questions on it. So the cause of cyclical vomiting syndrome is unknown. It does seem like pediatric patients are more prone than adults to this, and it is associated with anxiety in many patients. Also, people with cyclical vomiting syndrome may also have associated migraines, and for that reason, there seems to be a potential association between the two. Sometimes cyclical vomiting syndrome in the literature is referred to as abdominal migraines. Now, cyclical vomiting syndrome goes through a cycle, hence the name, right? So there's kind of three phases of cyclical vomiting syndrome. The first is the prodromal phase. The prodromal phase can last anywhere from months to even years, where the patient has an increasing number of symptoms. They may experience early morning nausea, they may have a fear of the actual vomiting and the stage to follow, and there may be abdominal discomfort associated during this prodromal phase. So it's just kind of a low-level discomfort, a nausea, and a little bit of pain. But then they go into the second phase, which is the hyperemetic phase. And this can be a very uncomfortable phase for the patient. It can last anywhere from 24 to 48 hours, where they have paroxysms of intense and persistent nausea and vomiting. And during this phase, the patient may throw up, as much as 5 to 6 times per hour. So it can be a very, very uncomfortable time for the patient. They can actually be incapacitated during this time and not able to go about their activities of daily living, and they may continue to have diffuse mild abdominal pain. Now again, the good news is this phase often only lasts for a couple of days at most, and then the patient moves on into the recovery phase, which can also last for days, weeks, or months, where they recover. There may be this period of relative wellness with normal eating patterns. They may regain the weight that they lost in the previous two phases, but of course they probably live in fear of the cycle and of returning back to the prodromal phase. So how do we manage the patient who might present to the emergency department with CVS, or chronic cyclical vomiting syndrome? Well, especially if they come in during the vomiting phase, which is when we are more likely to see them, the patient may require fluid resuscitation just from the fluid loss of vomiting. Antiemetics may be used. However, it has been noted that antiemetics are most effective when given very early in the hyperemetic phase. The longer the patient waits to come in, the less effective the antiemetics will be. So getting those antiemetics on board early is to the patient's advantage. Now, during the hyperemetic phase, they may have either gastritis or esophagitis, so proton pump inhibitors to reduce acidity of the stomach can be comforting for these patients. We also find that patients may respond to medications used to treat migraine headaches. So those medications may be used here. And then it has also been noted that patients are less nauseated and less likely to vomit when they're sleeping. So sometimes during the hyperemetic phase, we may give them an anxiolytic to induce sleep, and that may help them sleep through that hyperemetic phase.